What is BPH and why is it causing your symptoms? It's a walnut-sized gland that surrounds the urethra. The urethra is the tube that carries urine from the bladder. And as men age, the prostate can enlarge. This is called benign prostatic hyperplasia. The enlarged prostate squeezes the urethra, making it harder to urinate. And patients may have symptoms like a weak or interrupted stream, straining, using their belly to try to help urinate. They have a feeling of incomplete emptying, frequent urination, especially at night, urgency, and dribbling, and sometimes the inability to urinate at all, which is called urinary retention. So, what is prostate artery embolization? This is a minimally invasive procedure. It's image guided. It's performed by our colleague, the interventional radiologist. We use a tiny catheter, which is about the width, actually smaller than the width of a spaghetti noodle. It's inserted through a small nick in the skin at the wrist or groin. And then using real-time x-ray guidance, the catheter is navigated through the arteries to the blood vessels that feed the prostate. Once the catheter is at the blood vessels for the prostate, microscopic particles, which are about the size of grains of sand, are injected into these arteries and really reduces the blood flow to the prostate. Without the blood supply, the prostate gradually shrinks, and that relieves pressure on the urethra. Usually the procedure takes about an hour to an hour and a half to perform. The patient's under conscious sedation, which means you're relaxed but awake. It's usually just an IV. There's no general anesthesia. There's no spinal block needed. Sometimes before the procedure, we'll get a CT scan to map the prostate arteries and confirm you're a good candidate. What is the evidence for PAE? There's a lot of evidence out there supporting PAE. In fact, it's now part of the AUA guidelines, the American Urology Association guidelines. And one of the studies done in 2020 was a sham controlled study where they looked at patients who had severe symptoms and they were randomized to PAE or to no treatment at all. And PAE produced a 13-point improvement in the IPSS score, which is a very dramatic improvement compared to patients who had sham studies. There were other studies looking at PAE versus TURP. TURP is what we call the transurethral resection of the prostate, or a roto-rooter. It's the gold standard historically for prostate treatments. And in this study, at 12 weeks, the symptom improvement was essentially the same between the two. At 2 years, the TURP had a little bit better IPSS improvement, but PAE had significantly fewer complications, 43 versus 78 adverse events. As far as retreatment, 21% of PAE patients required a TURP after 2 years from the initial procedure. There was another study called the Salem IDE study in 2018, looking at 45 patients, saw a significant improvement in IPSS, and more importantly, no severe adverse events, no non-target embolization, which means other organs besides the prostate were embolized, and no negative effects on erectile or sexual function. The largest series done is called the Bhatia Large Cohort Study, over 1,000 patients followed up to 5 years. And here they saw that the IPSS scores dropped from 23 to 7 just a few months from the procedure and remained at 9 for 4 to 5 years. 94% of patients who had a catheter coming in were catheter-free at 3 months, and most patients were off their BPH medications at 1 year. Less than 1% of patients had any sort of serious adverse events. Looking at a bunch of studies pooled, there was a Cochrane systematic review that was done in 2022 comparing PAE to TURP, and here we saw symptom relief, quality of life were similar between PAE and TURP, but PAE had much fewer adverse events, although it did have a higher retreatment rate. What are the benefits then of PAE? Well, there's a significant improvement in symptoms. Most studies, again, show IPSS scores dropping dramatically. There's quality of life improvement by 60 to 65%. It's outpatient, you go home the same day. Fast recovery, normal activities usually within 1 to 2 weeks. There's no incision, there's no catheter, there's no urinary bleeding typically. It's not performed in the hospital. There's a low risk to sexual function. Erectile function is preserved in everyone, and the amount of retrograde ejaculation that occurs with PAE is less than 2%. PAE is very effective for large prostates. 60 grams or higher may be patients that do well with a PAE. The larger the prostate, the more difficult it is to do an effective TURP. PAE can be performed on patients who are taking blood thinners, patients who are poor surgical candidates. PAE has a high rate of catheter independence. If you have a catheter coming in, 94% are free of the catheter after the procedure at the 3-month mark. Most patients are able to stop their BPH medications. Risks and side effects of PAE. There's post-embolization syndrome, which is really not a complication as expected. That's mild pelvic discomfort, such as abdominal discomfort, burning with urination, more frequency. This is usually managed with over-the-counter medications and is temporary. Less than 10% of patients may have some blood in the urine. A small percentage of patients might have some temporary inability to urinate. Blood in the semen is also rare after the procedure. And of course, you might have some bruising at the wrist or groin site where the procedure was done. Rare but serious complications, less than 1%. Non-target embolization, for example, particles going to unintended areas such as the bladder or rectum. Getting a urinary tract infection or urosepsis is rare. Prostate tissue sloughing, where you may have to go back and remove some prostate tissue after the PAE, is very uncommon. PAE in comparison to TURP, again, patients perceive similar improvement in symptoms and quality in life for TURP and PAE. TURP objectively can give you a better improvement in your flow rate, and it can reduce prostate volume more. PAE, however, has significantly less adverse events than TURP and does not affect ejaculatory function like a TURP. There is a retreatment rate with PAE. About 20% of men may need another procedure within 2 to 5 years. With TURP, that rate is lower. PAE recovery is much shorter than with a TURP, usually 1 to 2 weeks versus 4 to 6 weeks. PAE uses conscious sedation, whereas TURP is going to require general or spinal anesthesia. So what to expect with PAE? Before the procedure, you might need a CT scan to map the arteries. On the day of the procedure usually takes an hour and a half. You'll go home the same day. You'll come in usually without having eaten anything because of the IV anesthesia. For that first week, you might have some mild discomfort, some urinary burning. This is normal and temporary. From 1 to 3 months, you should notice gradual improvement. The prostate continues to shrink. Most patients notice significant improvement by 4 to 6 weeks, and maximum benefit is usually at 3 to 6 months. And benefits are sustained up to 4 to 5 years in the largest studies. There is a chance you might need a different procedure if the PAE is not enough to improve your symptoms. Who makes a good candidate for PAE? Patients who have moderate to severe BPH symptoms, such as an IPSS greater than 13, who have tried medications without adequate relief. Patients with large prostates, especially greater than 60 grams. Patients who want to preserve sexual function. If you're in urinary retention, you may be a good candidate for PAE. Patients who are not good candidates for surgery due to their age, medical conditions, blood thinner status. Patients who have blood in the urine due to the prostate are also good candidates for PAE. Who's not a good candidate? If you have tortuous anatomy, the anatomy is critical in order for the radiologist to be able to reach the prostate. That could happen in a patient, for example, who's a heavy smoker. Patients who have active urinary tract infections should be managed for their infection first. If you have prostate cancer, PAE is not a treatment for prostate cancer. If your bladder is not functional, PAE may not be able to help your situation out. So at this point, if PAE sounds like an attractive option for you, we'll make sure that your history is adequate and suitable for PAE, and also have you talk to the radiologist to get a better understanding of the procedure itself. Afterwards, we will, at the urology place, continue to follow you and make sure you continue to do well. Thank you for your time.